He rose to become one of the best, easily one of the best 3 or 4 that we have at the Christian Medical College Vellore. And I say this because it's difficult to combine all this. And I think many of you say this, that it's difficult to be caring, compassionate, at the same time be kind to patients, at the same time do a lot of good work, at the same time visit mission hospitals, at the same time, how can one do all this is what I've heard many of us say. But Dr. Deepak Abraham has actually done this in real life. He's certainly one of the best surgeons that you can come across, excellent surgical skills, and we've been blessed because he's operated some of your relatives, but he even came here to help us with premolar surgery. Someone who is extremely skillful at work. Someone who does not say that I have a computer in front of me, I have to enter all this data, how can I be kind to patients? This I've heard from patients. The love, the empathy that he has shared with them and how that has helped them in their lives as they moved on. And people would continue to come, just to be with him, to listen to him, and to be touched by him. But he also excelled. It's not very often that surgeons do extremely well in the academic world. He went to Australia, and one of the top people in the world took him to do a PhD, so he is not only a surgeon, he's not only a physician, but he's a researcher and a scientist. And I say all this because my son, who trained with him, under him, tells me all this about how Deepak has mentored him and helped him to grow. And he told me that, Appa, you are important, but Dr. Deepak is much more important in my life because he's shown me the way. He's shown me a model, and he's a role model for all of us. So, presenting to you an absolutely excellent surgeon, a scientist, a researcher, a physician, and most importantly, a teacher, a trainer. He won the Best Teacher Award in CMC and would have got it every year if there was a provision for that. And today, he is at the top of his career. Having done all this, CMC, having recognized his talent, requested him to be the Associate Director for Human Resource Development. So when I asked some of you to help me with human resource development, it was keeping Deepak in mind. Can I find somebody amongst you who would do what Deepak has done for CMC, identified people, taught them, trained them, helped them grow. So shall we put our hands together to the person I will call the man presenting to us.
Good morning, friends, and I don't know what to say when I hear that introduction. I think the talk is over. I'm really honored and privileged to be here. This is my second visit to this podium. Maybe about 7 years ago when I came for the Foundation Day, when I gave a talk, but that was without PowerPoint. But as Sir mentioned, he was a mentor to me. And today I am what I am because of what he has done in my life. And when I say, actually I'm here for a completely different reason. And the thought process and the mentality right now is one of gratitude. Gratitude that I have received from BCMCH. And my dad had two setbacks back to back. Started, and I'd like to just narrate a story just to tell you that you're doing things right. Maybe just refine it, you would get better. This was 2 weeks ago. My dad, my brother had come from the US, noted that my dad was staggering in his walk, called me and said, Papa is not normal. We need to, why don't we just arrange a checkup for him? So I said, no problem. So that was around 12 o'clock in the afternoon. I called one of my friends here, organized an appointment with the neurologist by 2:30, had a scan appointment by 3. As the scan was being done, the radiologist called the neurosurgeon and said he needs to go to theater. He's got a very large bilateral subdural. And you won't believe it, from the radiology suite, he went into the neuro HDU, and then from there to theater. 10 days later, I was back here after the surgery, brought him for a review, had his sutures removed, and was told to come back in a month. I left back to Vellore. The day I reached that morning, my mom calls me at night and says he's developed very severe abdominal pain, right upper quadrant, and vomiting. And to cut a long story short, he had a gangrenous cholecystitis, needed a laparoscopic cholecystectomy at the urgent. And we did that within 15 hours of the onset of symptoms. And today he is fine, actually discharged and gone home. The story would have been completely different if care was not provided at the right time, in the right way. And I'm really grateful to BCMCH for this, which was my personal story, to tell you why I'm so grateful to be here to speak. When Dr. George Chandy asked me, can you do the talk you gave to CMC Ludhiana? I said, sir, the talk is always ready, not thinking so many things. One, I didn't have my computer, I didn't have my talk, and all my paraphernalia you see me on me right now is borrowed. I'm here for a completely different purpose. And but I said I'll do it because I'm grateful. And I'd like to just start with this prelude. Teachers, and all of you are teachers, and there are students I can see. But teachers have 3 loves: the love of learning, the love of learners, and the love of bringing the first 2 loves together. If you get this right, you will get life right as a medical educationist. Because it's not just about learning, it's not about the learner, it's bringing both together and loving both together. And that will set things right. This was actually said about, this was an epitaph on one of the finest surgeons this country has seen, and in whose name I actually did this oration a couple of months ago. And this was said about him. He had the love of learning, the love of learners, and the love of bringing the first 2 loves together. If we make this our story, we'll find life really meaningful. And as the title says, practicing the art and science of medicine as calling. And I'd like to just focus on the art and the science, but more possibly on the art, because at this point of life where I've reached, I've realized that, as Sir said, you've reached a peak in your science and you keep sharpening your skills, but then you realize if you want science to be more effective, you need to be good at the art of it, and the art of presenting the science. And when I teach medical students, I said, you must learn the art of presenting signs and symptoms to demonstrate, the science of the illness. And that will get you in the right place. So this can be subtitled or shortened to title it as Medicine as a Calling. And the disclosure, this is a story, a series of real life stories. And all permissions have been obtained from these individuals. Some of them you may be knowing. Some of them are your neighbors. And this is also to convey to you the power of storytelling. And I know I'm using PowerPoint, but actually the story comes more powerfully when I don't use PowerPoint. Because PowerPoint is meant for those who have no power and no point. Yeah? But I'm using that now primarily to bring to you just the illustrations and the stories. This is dedicated always when I do this, I dedicate this to two of my teachers. One was Professor K. Shankaran. He was the teacher of my professor of surgery at Kottayam Medical College. I'll let you in on a secret. I never wanted to be a surgeon. I wanted to be a physician. I was good at general medicine and I wanted to become that. But over the time, what happened, the way he taught surgery, the way he made it simple and easy to grasp, I switched and became a surgeon. The other is my life mentor. He's Professor Arvindan Nair. He's the one who made me today what I am. Our association with him, my association with him goes back now to 30 years. And he literally picked me, came to the mission hospital and called me and said, come, I need you to come back to Vellore. And he identified the gifts which I have had and then said, you should use this. And today I can say, all I am today is because of what he's done. And then I dedicate this to all my students. These are my fellows who've gone through our department over the last, we are a department which is 12 years old. In 12 years, we've had quite a few people who've gone through us for significant periods of time. Maybe not fellowship, but maybe more, some with surgery, higher surgical training, some with fellowship, some just working with us. But, this is dedicated also to a set of future students who are not known yet. And life is all about passing on what you receive. And I heard that in the prayer, this is not meant for us, this is meant for others. But when you say it's not meant for you, it's actually to incorporate this and pass it on to others. Imbibe this and then pass it on to others. And in this outline of my talk, I'm actually speaking about a legend. I'm speaking about a legacy. Did it go off? Yeah. Speak about a legend, speak about a legacy. Just go back up to show you what I'm... The legend, the legacy, the league, and the life lessons. And this would be how my talk would go. And I'm speaking about this gentleman who I've not seen, actually working. I saw him later on in life, post-below knee amputation, on a wheelchair, being pushed by my mentor. He lived in a mission hospital, which was 40 kilometers from Vellore. And to dress his wound, my boss, my mentor, would travel in a car, bring him back to hospital, do the dressing, and take him back another 40 kilometers. Every day, that was his job. He wouldn't delegate that to anybody else. But in his heyday, he was a legend. And the legend was because, he was an exquisite surgeon. And he was so quick at surgery. Okay, so it's not coming up here, it's coming up there, that's fine. So he was an exquisite surgeon. And this exquisite surgeon was so famous for his skill and speed in those days. And those days we had needles which had the eye and you had to thread the needle to feed. And there were only 1 or 2 nurses who could match his speed. A cholecystectomy would be done in 15 minutes flat. But there were only assistants who could match him, very few people who could do that. And his right subcostal incision with 1 incision would go through the whole abdomen and often nick the liver. That was how definite he was and clear he was about his surgical skills. More importantly was the skill of diagnosis. He was just not a good surgeon. In those days, we did not have PACs, we did not have investigations ready. Patients would come from various parts of the country, Bhutan, Sikkim, Northeast. People would come in and get admitted in the private ward of CMC. And one floor was usually Dr. Fenn's patients. Dr. Fenn had a floor, 40 beds, where patients have come without workup. And the registrar's job is to work the patient up at night. And next morning when he comes for rounds, present the whole diagnosis, investigations without looking at the chart. And many residents would fall by the wayside because they couldn't keep pace with him or match up to his expectations. So here was an expert clinician. He was also an exemplary teacher. This exemplary teacher was very skilled at handling students. He had skill of handling the undergraduates like his children, because he was not married. And his house was a beehive of medical students who used to go to be with him because he was their dad. But when it came to residency, he was tough, because his way of handling MS General Surgery PGs either made you or broke you. And there are many who would break or make. And then he would go on to become a colleague. And that level, he would then again take you back as his younger brother. And that was his style of presenting. And finally, he was also extremely far-sighted. And the reason I say far-sighted is because in those days, 1960, there's a register there. There's not so great in the resolution. There's a register there in 1968. That was the year I was born. He had data of patients. There was no PAC system. He used to send volunteers on this, you can see that map I've marked out, on a train to various parts of the country to get data back. And he would then use that for publishing. Not only publishing, just improving patient care. And these are registers we still have in our office of data. And this data had postcards like this. This postcard was reply paid. Patient would send it and they would say, I am well. Patient has been asked to come. You can see this was the way they did it in the 70s and the 80s. But the data was from the 60s. And that data is still available with us in our office. And I saw his extremely far-sighted nature identifying endocrine surgery as a subspecialty of general surgery in the 70s, when nobody even thought about it. And today, we are reaping the benefits, and there's no more powerful leadership tool than your own personal example, and you could see that in Dr. Fenn. And he took this to a completely different level, and we realized that we are people who are holding on to this legacy which he's passed on to us. And this needs to then become something we build on. And as I said, legacy, that's actually Dr. Fenn and Dr. Nair. Dr. Nair is my mentor. His mentor was Dr. Fenn. And Dr. Fenn took him under his wings as his son, built him up, and he spent 40 years in CMC. He did not do his UG, he did not do his PG. He came in directly and worked under Fenn first as a junior doctor, then as a surgeon. He did his surgery training in Madurai. Then he identified three of us. That's my colleague Paul in the light colored suit, and the other one was Ben, who worked with us now, lives in the US. And finally, we identified the next generation. And you can see Dr. George Chandy said was his son, his son-in-law, but son in grace, let's call it. And Anish, who was with him. And finally, we've also identified the next generation. So our legacy goes. But our legacy started when one man in the 60s thought endocrine surgery, believed that this could be a subspecialty, which we do. So legacy is not what I did for myself. It's what I'm doing for the next generation. Often headship brings on a sense of fiefdom. And often headship will tell us that I'm ruling. I rule the roost. No, it's not I rule the roost. It is I building the next generation and building for the next level of people to come through. That brought us to the league of what we do today. And now we are a high volume endocrine surgery department. We do about 1,400 operations a year. We have only 15 beds. So you can see our turnover. We do 25 operations in a week on Tuesday and a Thursday with an admission day on Wednesday. So what I do on Tuesday has to be discharged on Wednesday to admit my patients for Thursday's list. So I have refined thyroidectomy to become daycare. So there are a set of patients who can leave the hospital within 24 hours, which is by definition daycare. Otherwise, we cannot manage. And why did we do that and how did we do that is because we maintained an audit. And surgery without audit is like playing cricket without keeping the score. And we need to keep auditing what we do in our work, what we do in our practice, patients, identifying KPIs or key performance indicators. And this is how we do it. We actually have this board. This board is a whiteboard written. We do our admissions, our discharges, our transference and transfer outs. And along with that, we write down, for example, in thyroidectomy, our hypoparathyroidism rate, recurrent laryngeal nerve rate, our chyle leak rate. And so we've identified 4 KPIs or bleeds. And this gets transferred on a weekly basis into an annual audit, and that is presented not only to the division of surgery, which is our big brother, but also to the external departments with similar centers which do good quality work and overseas too. And you can see that this is a culture where you bring an attitude of auditing ourselves and looking at us and say, where did we go wrong? How did we do it? How do we improve? And that is done weekly, not monthly, not yearly, because often we just forget about our complications. And you can see this behind this mask, you can see the joy of this registrar. She is a resident now doing her MCH, but she was a non-PG working with us, and she was presenting her audit. And we had 16 thyroidectomies done that week, total thyroidectomies. 16 total thyroidectomies done that week. No hypoparathyroidism, no nerve injury. That was the first week when we found no hypoparathyroidism in any patient. That just shows you have to keep refining. And that refining, that auditing is very, very crucial. And you can see, as I said, we do 646 pre-COVID. We are bouncing back from that. This year we've reached again over 600. And these are again monitored by 4 KPIs: hypocalcemia, hemorrhage, recurrent laryngeal nerve injury, and chyle leak. And if you look at those numbers, it's not so clear on the screen, but every year we've been getting better. But it may be only by 0.5, 0.3, 0.2, but that's better. And as you keep doing better and better, you will keep improving those skills. And all these, maybe for the first 10 years of being in active endocrine surgery, when I did this, I focused on the how. Focused on how to get this better, how to keep doing this better, how to improve outcomes, how to use lesser laryngeal devices, how to decrease operating time, how to make patients. We have a 4-hour daycare slot, and we could do up to 3 thyroidectomies in that slot, which is, you have to be really good at it to get it done. But what I realize? Practice does not make you perfect. Audited practices will make you perfect. Practice will only make you permanent in the way you've done it. And only in improving and auditing will you improve and get better. And that is the lesson learned. The next thing I'd like to bring about is about research. Now, as Sir said, yes, I took up research not because it didn't flow from me. but I had to learn it. And I learned it when I became a professor of surgery. When I was nearing becoming a professor of surgery, that's about 8-10 years of clinical practice of academic appointment. I went to Australia, and I was working on medullary thyroid cancer. But you know what? Research came up in me because I realized it is relevant. It is relevant for clinical practice and patient outcomes. 2, as you keep doing research, you refine your outcomes. And as you keep refining your outcomes, you need to reorganize your schedules to make research fit in. And finally, as you do research raises opportunities for more research. But you shouldn't do research for the sake of research. You should do research for the sake of patient-related outcomes. And that will get you better. And you can see this, my journey when in Sydney. I must say that I'm the second Indian who worked in this unit for the last 45 years. The last person was 20 years ahead. Now I went 10 years before now. And these are the who's who of endocrine surgery in the world. But my boss is here in the center. He's the one standing next to the railing. Is Bruce Robinson. Bruce Robinson was the dean of University of Sydney. He's an endocrinologist. He took me under his wings. He was my guide for my PhD. And even today, he calls me, rings me, and asks me, how are you doing? Because he saw some potential that, this person has. And when I recently communicated with him, he called and said, I want to fix a time to speak to you. And when I made the presentation or my dilemma to him, he said, you must take it because this is the time when you should do it. And, as a recognition of that, what you see on the left extreme is the Royal Australasian College of Surgeons has an annual meeting. And each section has a distinguished visitor. I'm the first Indian to be there as the visitor to the Royal Australasian College of Surgeons as their distinguished professor. That is a story in itself. But I'm saying it's not because of me, but it's because of what's happened in the past in life. And the lesson learned here is dream big, but you must start small. Most important, you need to start. And these dreams will, take you to the place where you become the peak or the pinnacle of your specialty, but only if you act on it and take small steps. I never knew that I would reach here, but today most of the endocrine surgery circle in the world is on first name terms where I can call and speak, and they call and ask me, how would you handle this and what would you do? And not only this, has also helped me get people positions overseas to go. The next in line, Anish, is now returning back from Melbourne. Sean would be going to the UK. Hopefully he will get the fellowship and work there. But the whole process is you're building a team. The next day I like to focus is on something on multidisciplinary. It's not about it's one person. We work as a team, and we work in teams of multiple MDTs. We do at least 3 MDTs a week. One with the endocrinologist, with nuclear physician, one with the pathologist and the radiation oncologist. We do breast cancer too, so which goes there, and most of the endocrine work stays here. But you need a good endocrinologist, you need a good radiologist, you need a good nuclear physician, you need a good radiation oncologist, you need a good medical oncologist, but most important, you need good communication between all of them to make this happen. It will not happen otherwise. Standing in silos will not work. Working together and making the patient the most important person. And you remember when we meet in our MDTs, we sit around a round table. There is no leader. The leader is, the patient is the one who's the center of all focus. And hence, multidisciplinary approach to handling patients becomes very, very crucial. And the lesson learned is in unity, there is support, there is harmony, and above all, there is synergy. Their outcomes just multiply, quadruple, much more than just doubling. And it will just get you to the point where you will see how beneficial it is. I'll tell you now a story. This is my own story with medullary thyroid cancer. Very few people are experts in this subdomain of endocrine surgery because it's a very rare cancer. As I told you, we do about 600 thyroidectomies, but there are only 10 to 15 MTCs in a year, and that is very high volume. Most surgeons would go through their career without even seeing an MTC. That's how rare it is. So it is, what I say, 1 to 2% of all thyroid cancers, and surgery is the mainstay. And there are no definitive randomized trials. But what I like to show is, you can see this. That small gray bar at the bottom is the reflection of medullary thyroid cancer, and that's how rare it is. But here's a story. Most patients with this disease, once it goes outside the thyroid, do not get a cure. They may live for some time, but most of them succumb to the disease over time. This is the story of a young, electronics engineer. He lived in this state. He saw his father's death summary. And this death summary was from a reputed cancer hospital in the state, and saw medullary thyroid cancer, Googled and checked it out and found out that this could be hereditary. He was not told about this hereditary component by the team who treated his father. And he was sitting on a thyroid swelling for over 3 years, and his person who he consulted said, don't do anything about it. However, he came to us, and to be sure, he had hereditary medullary thyroid cancer with calcitonins going through the roof, and also, disease which is showing extensive disease in the chest, in the neck, in the chest, in mediastinum, and in the liver. And so we had this whole MDT again, which decided this was 2014. That time we didn't even have many of the drugs which is available today. But we had a decision made that let's go and give him sorafenib, which is a tyrosine kinase inhibitor, twice daily, and then review in 3 months. We've not done it, but it was the power of the team which made that decision. And he went through hand-foot syndrome, the difficulty of handling this, and came out with shrinking of the disease based on the tyrosine kinase inhibitors which he got, and we found that he was getting better. Then we went and did a surgery which was like 14 hours, thyroid plus mediastinal dissection, took that all out, and he became, his calcitonin, which was in the 30,000s, had dropped down to 4,000s. And we thought, we've got him sorted out. And he was doing well. And his calcitonins dropped, he was improving. And then suddenly we hit a roadblock. We tried various options. We had PRRT. This is one option where you consider giving lutetium therapy. That was not working. MIBG was not working. And we tried transarterial chemoembolization for liver lesions. Then we were searching the world actually for trials. He was smart. He always was on clinicaltrials.gov. He would call me and said, sir, this trial has opened up, can we contact? So when this LOXO 292 trial opened, the PI for this trial was my boss in Sydney for Australia. Through him, I got connected to the PI for this trial in Singapore, and sent all the documents to him and said, can you enroll this person? He said, let him come over. So he had to go first on his own steam to Singapore, got enrolled into LOXO 292, and he's still on this trial, and his calcitonins have reached near normal, and he's living basically a normal life, and you can hear his story now.
It was in August 2014. I reached CMC Vellore after diagnosed with medullary thyroid carcinoma. We first met Dr. Deepak in Endocrine Surgery department. I stayed around 12 days in hospital after surgery. With the help of Dr. Deepak, we got into a clinical trial in National Cancer Center, Singapore, in October 2018. I must say, all good things in treatment happened to me through CMC Vellore. I am very much thankful to all the doctors in CMC, especially to Dr. Deepak. Thank you, doctor. Please continue your good work.
This
It
man
was in August 2014. I reached CMC Vellore after diagnosed with.
Okay, I think it's playing again. He would not have been alive today if it was not for having received Loxo. Today that drug has become standard of care. It's what we call selpercatinib, and that is standard of care. Now it is available in the market. It costs a huge amount, but he still gets this drug free, and he flies to Singapore to get it every 3 months. So persistence pays off. That's the next lesson I learned in life. Don't give up. Don't give up on patients too easily. You will have an opportunity to keep on working and getting better and better. This is another one part of life which is inevitable for a surgeon. I label it as part 1 and part 2. This patient lives a stone's throw from here. He is a physician. He had a very unfortunate story. He had a pituitary tumor which was secreting cortisol and ACTH, and then he had multiple brain surgeries or pituitary surgeries, radiation, all failed. And the only answer now is to go ahead and do a bilateral adrenalectomy. And this gentleman actually came to us during COVID, and he was completely neglected during COVID. His EF was 35%. He was swollen, bloated, oozing lesions in the leg, which are all skin peeled off, and hyperproteinemia. And all of this put together, he was on a wheelchair. He couldn't even walk. He was 4'9" or 5'1", and he was 125 kilos. And you can see that CT scan, the resolution is not great, but you can see there's so much of fat in the abdomen, and that's his kidneys, and the adrenals are really sitting high up in the abdomen. Disasters happen. This gentleman, as we operated, the right adrenal went smooth. The left adrenal, we struggled and we got stuck. It had bleeding. We had to convert. We opened, and final biopsy had no adrenal in the specimen. It was pancreas which came out. It was the adrenal was not there. Well, this is reality. Now I can hear the whoosh whoosh, but it's true. This can happen. And we took him out. We took him up immediately when we realized that the adrenal is not out. Said we'll take it up again. We opened him, got the adrenal out, and he got cured. Today he's walking. He's cycling. Adrenal out, and he got cured. Today he's walking. He's cycling. And I went to his house to visit him. Last time I was here actually for the operation for Dr. Pramila. And he's grateful. You can see his face has become Nelson's because of the hyperpigmentation, because of the ACTH stimulation which is going on. But anyway, that's first part of the inevitable story of complications. And no matter what measures are taken, doctors will sometimes falter. And it isn't reasonable to ask that we achieve perfection. What is reasonable to ask is that we never cease to aim for it. And I've learned a lesson here. Stick close to your patients, but stick closer to those who have complications. Don't give up on them. The next is another story, inevitable part 2. This is a story of an orphan who fought all odds. She's actually from Bangalore. Her name is Tazayan. She's a doctor. She actually went on to do medicine. She became a physician, got married, had a bright future ahead, got married to an IT professional, and at age 24, after this child was born, she developed abdominal pain, and she had an adrenocortical cancer, which was secreting aldosterone, which is extremely rare. And she underwent a radical adrenalectomy. Year 2, she recurred again. PET scan showed no further disease. We again went back in and took out her remaining the recurrence. And 1 year later, again developed a third recurrence. And we said, we'll do it again because it's possible. Because that time we did a complete, like a compartment excision, diaphragm out, kidney out, it was radical. We reconstructed the diaphragm with a mesh. And she got better for another 6 to 8 months and had disease again. And then we gave up and said, we've reached a point when we can't do anything more. But here's the story of the husband who tells us, he sent me this video.
Hello, My name is Nihal Ahmed. I was a caregiver and a husband to my wife who succumbed to adrenocortical carcinoma, which is considered 1 in a million in terms of numbers. Being diagnosed at just 25 years when my son was 9 months old, we embarked on an indefinite and uncertain path, a path which would test our patience beyond the ordinary as a family. I still remember the day when Dr. Nihal Thomas and Dr. Deepak Abraham consoled us saying, "You're a doctor and we will try all that we can so you can live not just for yourself, your son and your family, but to many patients who you can treat as a medico." We knew we were in the right hands then itself. I can indeed vouch that we were taken care with utmost affection and love by the whole team, right from endocrinology to oncology at CMC Vellore. The simplicity and humbleness when Dr. Deepak visited our house in Bangalore, knowing that my wife has just a few months to live to boost our morale, from time to time clearly showed how much he reciprocated our love. It was this love that drew him even on my wife's deathbed, and his pat on her cheek with just a few minutes left to depart this world, calling her out, "Tazain, Tazain." I am sure if she could, she would come out of the pangs of death with just the tone of Dr. Deepak calling her name out. The night before her death and after a 3-year-old battle, I had given consent to not take her to ICU if situation worsens for her own good. I was torn into pieces inside, but I had to let her go. I was helpless. She knew what's in store. She told me she was helpless. She told that she would die of septicemia. I would realize only later that she became a doctor just to know of her own deaths step by step, just like in the textbook. She served humanity in the limited years of her life as a person and as a doctor. I was told by the palliation team that she has no regrets in life. She lived life to the fullest and that she got a beautiful family, a loving husband and an adorable son, and that she regretted not become a postgraduate and that her son would think that his mama was just an MBBS. The other regret being that our son is too young to understand why his mama left him so early. I am sure she's in a better place, free of any pain or agony. I am sure our son would fulfill his mama's dream and realize that the sacrifices, the hardships which we underwent at every stage. Death, while a taboo topic, is the harsh reality. It doesn't mean we forget to live our lives. There has to be a meaning and purpose of our life. Only then can we achieve what we were truly created for. I would like to congratulate the team at CMC for going beyond the line of duty and to continue their service to humanity. Thank you.
His name is Nihal Ahmed. You know, he used to travel to the US and he went to Michigan, and there is the who's who in adrenocortical cancer is a person by name Gary Hammer, and showed Gary Hammer this discharge summary. And Gary Hammer said, "Do you get this treatment like this in Vellore, in India?" So that was the shock he had when he saw the kind of care we had given him. So the point is...
Hello, my name is...
The lesson learned is death is not a defeat. Death is an opportunity to celebrate the life well lived. You know, and we as clinicians, we need to bring this in of handling death, of handling people who die. And I'm sure the palliative team here will understand what I'm saying. But it's not only the role of the palliative care. It's actually the role of even a cutting-edge surgeon or a physician who handles death in an ICU setting. Instead of mourning their death, you celebrate their life. And we are a very busy unit, actually extremely busy. You won't believe it, the kind of work we do. But you know, the aim is to make the working place a happening place. And that's why I said I focus myself in the first decade of endocrine surgery on refining how to do it. Today my focus is on why we do what we do. And this happens around what we call as our Maitri Bible study, which happens on a Friday. And in this Bible study, the focus there is to actually teach people why we do what we do. And when they are doing 25 operations, 30 operations a week and handling discharges and admitting and doing all the outpatient work, they get burnt out. But it's not because of that. Understanding why becomes so true. This is the story of my resident. She was from a different faith, from a different background, never worked in CMC, came to Vellore, did her MCH because her husband was doing cardiothoracic. And in her words, she said the most important time of the year in the 3 years she spent with us was the Friday morning. And that Friday morning taught her what character building is, why we do what we do, inculcate values for life, and learning from sharing others' experiences. And today she's an advocate of CMC's ethos and values in a completely corporate culture in the city of Madurai. And I go to visit her whenever I go past that area, and I say, she's so excited to say, so when I go through an operation and I'm handling a difficult case, the thing which goes through my mind is, what would Sir do here? That's the thought process which goes through her mind when she handles a difficult problem, and says, even before I can call you, I will go through what you would have done in this situation and follow that. And so then the league lessons I've learned is, be part of the minority, not the majority. Be the voice for the voiceless, take the road less traveled. God is your waymaker. We will be the salt, the light, and the city on the hill. Now I come to, these small changes we do make a big impact in life. And being excellent is different from doing excellently well. Doing excellently well is an end game. Being excellent is a habit. It's a culture you develop. And in being excellent, you're willing to consider others better than yourselves. And in doing excellently well, you are climbing that ladder. And in becoming the top, you are actually willing to stamp on other people, tread on other people's toes, get to the top and win the rat race. But the point is, when you win the rat race, even when you become number one, you're still a rat. So it's important to understand that life needs to be looked differently. And being excellent is different from doing excellently well. And I focus on being excellent rather than doing excellently well. And this is my personal story, and this is very vulnerable, so bear with me as we go through this. And I'll start with one habit I had in life. When I was young, my parents taught me, read one chapter of Proverbs every day. If you do that, you do it 31 days, you'll do it 12 times a year, you do it 5 years in your life, you will, mark my words, you will not be the same. In fact, I started redoing that now. I do Proverbs again every day, one chapter, and just let that sink in, and you'll see life changes within you, and you'll be a blessing. And this verse has become so true. Beyond all understanding, trust in the Lord, and He's healing to your body and refreshment to your bones. And one such example was, it's very bad. I think our projector we should change. This is actually, those of you who are teachers from Kottayam Medical College, you'll understand this is the house surgeon's quarters where I lived. And during my internship, I went to my mentor and I said, sir, what do I do in life? He said, do one thing, every day at the same point of time in the day, apart from your morning quiet time, or come aside and ask 3 questions. And these 3 questions were, what do you want me to go? What do you want me to do with my life? And what is my calling? And I asked this for 1 year, every day at lunchtime. At lunchtime meant whatever time was lunch. If you didn't have lunch, you didn't pray that day. But it was 1 o'clock, 2 o'clock, 4 o'clock, whatever time, this question was asked. And this changed my life, actually. I realized my calling. I realized I'm called to be a teacher and a role model to medical students. And this was when I was 23 years old. And I had no clue where I'm going, didn't know where I'm going to be working. But I just clung on to this to say I'm called to be a teacher. 3 of us were working together during our internship. to study. That was the first year of the All India PG exam, and to study for that. And we three sat down to study. And in the batch, there's a buzz which goes around. If anybody gets, these three guys will get. And in that batch, only 2 of them got. I did not get. And the lesson I learned through that is, the third musketeer failed. But failure is not final. Failure is not fatal. And the lesson I've learned now is failure is sometimes essential. Because only when you have failures will you then look at opportunities which God is opening. Otherwise, you're well set in your ways. And hence, this became a story which I have learned to say failure is sometimes essential in life. And that took me actually to a road less traveled. I went home. My parents were living in Bangalore city from Kerala, and I said I'd like to work in a mission hospital called Ottanchatram. They couldn't even pronounce it. They said that's a tongue twister for me. But surprisingly, they let me go. But when I went there, the world said, get what you can what you get, sit on that can as long as you can. But the word says, in becoming the last, you become the first. In yielding, there's a reward. In surrender, there's victory. And in dying, there's a life. And that was the counterculture I learned, incorporated, imbibed, and made it mine. To say you don't have to be on the top to get to the top. You can actually have a different route to get there. And this counterculture lifestyle, only dead fish go downstream, live fish go upstream. And that brought me to something else, which is my morning journal. So I had to decide in life, I'm either an owl or a fowl. So I was a fowl. So I woke up every morning at 4 a.m. And this 4 a.m. time became very precious to me. Not only was it a Bible study time, but it was also my own life journey, where this is, by the way, I'm talking about my 20s. And I realized that I'm called to be, this, ignited my passion and found my calling. And the call to be a teacher became even more clear. And to cut a long story short, I came to Vellore. So Dr. Nair, who I've showed here, is the one who pulled me in, and he said, be excellent, but be humble. Be willing and be others oriented. You become the dharti. The dharti is actually the dust of the earth. You become the dust of the earth to become, excellent for the work you've done. And the first day I was in CMC back as faculty, the verse was, he who began a good work in you will bring it to completion. And that is reality for me today. And you can see 2 decades later, I got the Best Teacher Award, which is not common to get, maybe 10 faculty in the whole career, about 50 years would get it. And that is what the students wrote for me. He said, gentleness and love while teaching or examining a patient has always amazed his students. Beyond the brilliance of his teaching, he was an inspiration for all. And that is basically become my story. And in life and living you need to act justly, you need to love mercy, you need to walk humbly. And if you get that right, humility becomes part of your nature. The problem is the moment you speak about humility, pride creeps in. Because that's how humility is. You can become proud. But when you combine that with justice, when you look at a situation, act justly for other people, love mercy, display the mercy to others, and finally you will walk humbly. And lessons on leadership I've learned now, as I said, I evolved my calling. I've evolved from becoming a teacher to becoming a role model and a mentor. Mentored not only to students, but to even people who live, maybe juniors, maybe colleagues. And leadership is not being in charge. Leadership is about taking care of those who are in your charge. And if you have listened to Simon Sinek, he speaks on servant leadership. He's not speaking from a biblical perspective, but he's speaking of values from the Bible. And when we help ourselves, we find moments of happiness. When we help others, we find lasting fulfillment. And I can say that in my life. And live in such a way. So this I've looked back and said, live in such a way that even if given another opportunity to live your life all over again, you would still choose to live it exactly the same way as you're living life now. And I could vouch for it, put my hand on my heart and say that's true for me too. This is the actor who, in the 10 Commandments, Moses, he goes to the burning bush and the voice calls out to him. God calls to him and asks him, what is in your hand? He said, your staff. Your staff is your identity, your income, and your influence. Medicine is a staff. In surrender there's a reward. In yielding there's victory. In becoming the last you become the first, and in dying there is life. So be patient-centric, be excellent, be compassionate, be others-oriented, and believe this is worth it. And this is my department and various people who've lived, and these are our families who are there right now. And I made it a point to put this young girl, who's our youngest faculty, who's not married, as the prime person, just to convey to the fact that, you give the people who are the least in your place the most importance. And life lessons are ongoing. The legacy is growing. The legend who Dr. A.S. Fenn I started with would approve of this. Thank you.
Nothing more to say. Shall we all rise and give this legend a standing ovation? Thank you, Deepak, for that inspirational talk. I'm sure we are guided, and we will, years later, I'm sure our students will be talking about you and about us. Thank you so much. Thank you very much for everyone for coming.